Hi guys. Sorry, how's it going? Hope you had a restful weekend, and I hope you're excited to kill it this brand new week. And this is week 8, right? So we're kind of in the middle of the semester, and today I'm gonna do what I always do, which is give you some feedback about what you submitted, and talk about what you need to submit by Sunday, and then of course cover 2 chapters, which is what we have for this week. All right, so let me try to share my screen. Let's go to Moodle, see what's up there. All right, so what you submitted today, for today or yesterday actually, was LO13. You had 2 case studies and then LO14. Concerning LO13, the ones that picked 9.1, it was cultural. If you read our textbook, one of those ladies had an allergic reaction. The other one was cultural. So it wasn't exactly the same, the case, which wants to show us that we need to investigate a little bit more, even if it looks like the same. The concerning the low, oh, and the other one, sorry. I want to make sure you understand that physical activity and exercise are not the same. Exercise is always physical activity. Physical activity is not always exercise. Let me say it again. Exercise is always physical activity. Physical activity is not always exercise. Exercise has to be planned, has to be part of a schedule, has to be repetitive, has to be included in a goal. Physical activity is different, okay? And if you still don't understand the difference, please revisit our textbook, okay? I gave specific feedback in the ones that submitted 9.2 concerning this one. But again, if you don't understand the difference between physical activity and exercise, please go back to our textbook. Now, LO14, I try to be really gracious with grading, and I think I was. A lot of you didn't give specific examples. You were just describing what you would say, but you didn't really say what, like, give me specific examples. Concerning the first one, which was about an open-ended question, if I can answer your question with one word, most likely it's not open-ended question. So what's your goal? If I can say power, or then it's not really an open-ended question. You're not promoting conversation. If you ask a lot of times, if you start the question with how are we going to do this? Why do you wanna? Why is your goal power? Then that is very different. So this is conversation. It's very, very different. And excuse me, what you're trying to do is help them open up and talk to you about it so you can understand more, right? That's what I wanted to say about LO14. All right, now for Sunday, 2 chapters, 2 LOs. LO15, let me go over it really quickly. So you see a document right here. It's a PDF. It's a Part Q Plus, okay? Which I think I have some. I'm going to show it to you. I'm going to share my screen and show it to you. Find somebody who doesn't know what that is. You can call your mom. You can ask your roommate, right? It has several pages. It gives you very specific instructions. Start with page 1 and move to whatever you have to move accordingly. All right. And then I say, First of all, put your personal information at the bottom. Okay, you have to sign it. They have to kind of sign it. Let's pretend it's official. Okay, and then based on their responses, what is your recommendation? When I say your recommendation, I don't want you to make some create some recommendation like based on your personal opinion. This is not about personal opinions. It's not subjective. It's really objective. All right. So the recommendation, as I say down here, is either in the Greek, not Greek, green bias, in the green or the red boxes. First or fourth page. If you stop at the first page, maybe that's where you find the recommendations. If you have to move to the next pages, again, there are specific instructions. Then maybe the recommendations are in the fourth page. It's not, excuse me, it's not your personal opinion. It's not. This is a tool, and you need to use it and go by whatever they tell us to go by. Okay? Include your client's characteristics, maybe age, gender, if that's relevant, or other information that they may give you. Okay? All right. Now, as you can see, I need a Word document with a recommendation along with a questionnaire, the Part Q plus. That's the questionnaire. So I want the questionnaire so I can see where you base your recommendations, and two, a Word document with their recommendations, because we collect information in order to make a decision. What was your decision? And then also you give me the questionnaire to understand why you decided what you decided. All right, let me stop sharing this. Let me start sharing this. This is really important. Please find somebody and actually do it. Don't BS me. Please, I know you can do it. Just take advantage of every opportunity I'm giving you. All right. So here, up here, either 2017, 2019, doesn't really matter. It's the same thing. This used to be Part Q. They changed the wording a little bit, and then they added all like page 2, 3, 4. That's why it's called Part Q plus. We're not using Part Q anymore. It's not enough. We're using Part Q plus. We used to use Part Q. And if you see my the rest of this video, I will explain why we need Part Q plus. Okay? So first, you read it, you understand it, and then you call somebody or you ask them those questions or you give it to them. All right? You answer those questions, and then here it says, if this happened, then okay. If this happened, then and then these are maybe recommendations. If you need to move to the next pages, you have to do 2, 3, 4, all the way down here. This has to be done anyway, whether you do the whole thing or you have a client that you need to do only page 1. Name, date, signature, and if there's a witness, and then another signature if you need from a partner with us. If you use pages 2 to 4, then you follow these kind of instructions. Don't get confused. It's pretty simple. You're supposed to use it by yourselves. It's supposed to be self-explanatory. Okay? Hope it's okay. All right, so I'm gonna share Moodle again. There we go. So this is Hello 15.2 documents. Hopefully it makes sense. If it doesn't, guess what? Office hours tomorrow. Okay. Now let me go back. Well, let me talk about LO 16. LO 16 is located at the end of the chapter in our textbook and at the end of the slideshow for chapter 16. It says in one paragraph, it's one, elaborate on how assessments could be used as a motivational device. At the same time, should you use caution? So your answer should be like, yes, but there are cases of whatever. Okay? Yes, and this is how. However, there's a second part down here. Everything is in the book and in the slideshow. Okay? Just study the material. And that's all we have for Sunday. Now, excuse me, let me drink some coffee. All right, that was good. I'll go ahead and start with the first chapter for today. I'll stop sharing this, and then I'll start sharing chapter 11. Very important chapter. Very, very, very important chapter. Short, but I'll explain why it is, the information is crucial, okay? So we're gonna talk about pre-participation physical activity, screening guidelines. So we'll have some guidelines that have to do with PA screening before you actually participate. So this whole thing happens before you actually start working out with the personal trainer. So this is something that you're doing in the very beginning, and this, you'll see why we're doing it. But we're doing it before, okay? Okay. Now, it says here, pre-participation screening process relates to contraindications for graded exercise testing. Sometimes we need to do some fitness tests, okay, in order to determine your, let's say, cardiorespiratory fitness level. And based on that information, then you can prescribe exercise customized for me, just me, okay? But before you actually put me on a treadmill or on a bike, you need to know if I'm healthy enough to do that, right? And this term here, we're gonna cover some terms today. It's called contraindication. It's something that you can prescribe. You can prescribe. It's going against whatever I have. So if I have knee issues, plyometrics is a contraindication. Okay, that's a simplistic example, but I hope you get it. And of course, you get what I just said. You get that extra information to make further decisions. Okay. Now, why is this important? We're gonna identify people with medical contraindications. We're gonna identify if somebody needs to be referred to a doctor, a specialist, so they can get clearance. We can identify if somebody needs to be participating in medically supervised physical activity program. That's a thing. But so you can exercise, but you have to be supervised by specific people, not a personal trainer. Okay. And if there are any other concerns that we should take into consideration, health or medical. Now, this edition of the book is based on the 10th edition of the ACSM Guidelines for Exercise Testing and Prescription, GETP. That's the acronym we're using, which is a book that we're going to use if you go towards the personal training, fitness management, concentration, and more specifically, it's part of PED212. Okay, so if you go toward there, we're going to definitely use this edition. It's a small book, but it's so much information. Anyway, so this one is very different or significantly different than the 9th edition. Okay, and ACSM came with the term, risk classification or risk stratification. And there was a specific procedure that we used to do that ACSM now was like, nah, we're taking it back. We're going to change it up a little bit. We're gonna use the physical activity history more, as you can see down here. Why? Because their intentions were good. However, they ended up creating more barriers for people who wanted to exercise. We had to refer a lot of people to doctors or specialists So in a way, instead of helping them exercise, facilitate that, we're creating more barriers. So they were like, no, yeah, it kind of backfired. So they took this back and they started using this, and we're going to see where we ended up. We're not using risk stratification anymore, at least for ACSM, okay? And I'll show you what we're using. It's an algorithm, okay? Now, we have two levels of screening. We have screening that the client can do by themselves, such as PARQ Plus, and we have screening and tools that only professionals can use, like doctors, okay? PARQ Plus, the EPAR X Plus, which is another one from Canada, PARQ Plus is from Canada. The Physical Activity Readiness Questionnaire for Everyone, which is in our textbook. These are all self-guided screening tools that you, and you can use all of them, most of them, okay? We recommend PARQ Plus as, very, very, like, the most basic one. What's cool about self-guided screening? It's cool because you can actually give it to your client. They can fill it out whenever they want. They can give it back to you. It's very convenient, right? However, it's self-report, which means I report whatever I want to report, or I report whatever I know I have. Maybe I don't even know if I have it, okay? So there are limitations when people are reporting health medical issues about themselves. And these are the ones that doctors can use, or professionals: the health history questionnaire, the medical examination clearance, and the pre-participation physical activity screening process. You see this one, right? It has specific steps, and it has specific instructions for each step. So this is the exercise, pre-participation, health screening questionnaire for exercise professional. So this is something that a professional would use to screen a client, not the client themselves, okay? Now, I'm gonna come back to this. This is the slide we're gonna stay for a while. This is the algorithm I was telling you about. I'll tell you in a little bit more specifically what we used to use and what other people had to know in order to take the ACSM CPT exam. But now, this is where we are. We practically ask 3 questions. Are you physically active the past 3 months? Have you been doing for the past 3 months 150 minute of moderate intensity physical activity per week, or 70 minutes of high intensity over a combination of both, 75, sorry. It can be a no, or it can be a yes. That's our first question. The second question is, do you have CMR disease? CMR stands for cardiovascular, metabolic, and renal disease. Cardiovascular disease, like you had a heart attack, right? Metabolic, like diabetes. And renal. Renal is, if you hear that word, which organ of the body do you think? Think, renal. If you said kidneys, you're right. So a disease that has to do with kidneys is CKD, chronic kidney disease, for example. So again, it can be a yes or a no. Now, the third question is, do you have any signs or symptoms of CMR? And which are those signs and symptoms? All right. This is something you should know, and hang in there. Excuse me. I'm going to explain them one by one. So these 2 slides have the signs and symptoms that we're using here. Okay. Pain, discomfort in those areas, right? That might result from ischemia. Again, there's going to be some terminology, medical terminology today. And the more you know now, the less you're going to have to struggle in PED212 if you need to take that, right? Ischemia is what? What do you think ischemia is? In simplistic terms, we have some blockage of this blood circulation, right? Which will result in a shortage of oxygen, right? That's enough for now. Number two, shortness of breath at rest or with mild exertion. So me having shortness of breath when I'm pushing it at 80% of my max or 90% of my max or even 100, it's expected and it should happen. It's normal. Having shortness of breath coming from my car, the parking lot, to the classroom or to my office, that's not right. Okay, so that can be an indication of cardiovascular issues or whatever. So those again are signs and symptoms. Okay, and for us, a sign is something that somebody else can see on us, and symptom is something that we feel. Dizziness or syncope. Syncope is loss of consciousness, and that may result from poor blood flow to the brain, again due to inadequate oxygen or cardiac output, pretty much. And the reason can be several cardiac disorders. Orthopnea or paroxysmal nocturnal dyspnea. Orthopnea. So in orthopnea, we have trouble breathing when we lay down. Okay, and paroxysmal nocturnal dyspnea, it happens when we start sleeping between the first 2 to 5 hours. Again, we cannot breathe, and what happens is it goes away if we sit at the side of the bed or we stand up. Okay, both are indicative of poor left ventricular function. Ankle edema. So here we have swelling. It can be bilateral or it can be unilateral. In general, it could suggest heart failure, blood clot, insufficiency of the veins, lymph system blockage, who knows. But it's enough to get that kind of information. Bilateral usually has to do with heart failure, unilateral has to do with venous thrombosis. Palpitations and tachycardia. Tachycardia means your heart rate is higher than normal. Palpitation is an uncomfortable sensation of your heartbeat. And it can be associated with a lot of heart conditions. Then we have calf pain when walking or intermittent claudication. It usually happens when it's uphill. It feels like, what's the word I'm looking for? Cramp. And it goes away up some minutes after you stop walking, right? It doesn't happen if you're not moving. And again, it has to do with lack of oxygenated blood flow. Heart murmurs has to do with blood circulating in our heart. Some of them are very innocent, some of them are not. So we need to figure that out. And then the last one is unusual fatigue or shortness of breath that occurs during light exertion or normal activity. Again, there's no strenuous activity, so we shouldn't be tired. We shouldn't have shortness of breath. So if we know the signs and symptoms and we ask them, again, they can say no, signs or symptoms, or yes. And based on their answers, they can go this way, they can go this way, whatever. And you can see that if they say yes here, and then they have no CMR, and then they have no signs and symptoms, you can see that they continue to moderate or vigorous physical activity, right? Another example, they say no here, yes CMR, yes signs and symptoms, right? So here we need MC. MC stands for medical clearance. So we refer them to a specialist, and then if they're okay with it, they go to light and moderate activity. So there are 1, 2, 3, 4, 5, 6, 7, 8 different scenarios that can come up after we ask those 3 questions: physical activity history, CMR, no CMR, signs and symptoms of CMR, or no signs and symptoms of CMR. I want you to stay in that algorithm and make sure you understand it. If not, ask me questions, okay? The American Association of Cardiovascular and Pulmonary Rehabilitation, they still use this certification. I'm not going to go over it here. We'll go over it in PED212. However, I just want to say that the risk certification that ACSM liked and promoted, they don't use it anymore. They use the algorithm. But some other organizations like the AACVPR, they still use it. Now, as you can see here, there's a difference between recommendations and requirements. So we do not require Part Q class, for example. We are recommending, okay? There's not enough data to make a more, like a bolder statement. So we stick with this, okay? That's the classification that you would end up if you would do the risk stratification. You would be low risk, moderate risk, or high risk, and based on that, the next step would be different. Contraindications to exercise testing. What is a contraindication? It's a clinical characteristic that individuals may have that may make physical activity more risky, okay? As I said again, if you have knee issues, that's a contraindication for plyometrics, okay? And then we have absolute versus relative contraindications. Guess who's more severe? You said absolute, you're absolutely right? So here we see some examples. And with absolute means that you stop. There's no way you go for the testing. Relative means, well, it depends. Let's ask the specialist. It may be a case where we could do it. Acute myocardial infarction. Myocardial infarction is, in simple terms, a more scientific way to say a heart attack. Okay, unstable angina. That's really the fact that is unstable. Angina is chest pain. The fact that is unstable is really worrying. Uncontrolled cardiarrhythmia. Arrhythmia again is when you don't have a specific rhythm in the heartbeat. It's arrhythmia. Okay. Active endocarditis. So here, what do you think you have? Have the endocardium. Remember when we talked about the heart, there's inflammation there. Symptomatic severe aortic stenosis. Stenosis. We talked about stenosis before, right? Decompensated heart failure. So here your heart is failing. Now we have acute pulmonary embolism. Embolism has to do with the lungs. Embolism means that the piece, like a blood clot, is stuck somewhere, and that blood clot here came from the lungs. Pulmonary infraction that has to do with the lungs or is related to the lungs. And deep venous thrombosis. Again, embolism is a type of thrombosis can be blood clot, it can be a piece of fat, it can be air, whatever, and that goes and travels throughout the body and then finds a place where that can go through, which means then that it blocks it, then blood cannot go through, which means oxygen cannot go through, boom, okay? Aortic dissection, which means like it just broke, opened up. Acute myocarditis, pericarditis, inflammation, myocardium and pericardium, and physical disability that precludes safe and adequate testing. The relative contraindications: known obstructive left main coronary artery stenosis, moderate severe aortic stenosis with uncertain relationship to symptoms, tachyarrhythmias, with uncontrolled ventricular rates, acquire advanced or complete heart block. Advanced is, as you may understand, a better case of a heart block than complete, right? They have different stages. Recent stroke or ischemia attack, mental impairment, and that's hyperthyroidism right down here, electrolyte imbalance, anemia. What's anemia? Very simplistic way to talk about it, to explain it, is iron deficiency, right? So I'm not going to explain all terms. I don't want to overwhelm you. I'll leave that for PED214. This is what we used to use for that risk stratification: the age, the family history, current smoking status, sedentary lifestyle, and BMI. We'll talk about BMI in the next chapter, same as hypertension, dyslipidemia, diabetes, and HDL. HDL actually was a factor that if you had higher than number, 16, you would get a plus point. Everything else was a risk factor. You would get negative. Okay. That's all I want you to know for now. I'm going to read the take-home points and then move to the next chapter. Pre-participation physical activity screening is a process that may include health, medical history, and informed consent of an individual client. The pre-participation PA screening gives the relative assurance that the client is ready and able, based on national guidelines such as from ACSM, to participate in the rigors of the physical activity training process. It is thus important that the EPC or CPT, in our case CPT, you're not going to be exercise physiologists right now, perform the pre-participation physical activity screening on their client. I'm going to stop sharing this. Please read our textbook. All the information is in there. If you have questions, just let me know, okay? All right, let's go chapter 12. This is a long chapter. Hang in there. I'm going to cover everything in the best way I can. All right, sharing my screen, chapter 12. There we go. So now your client is cleared. You can do the fitness assessments that you need without worrying that an event may happen. Okay, now, why do we need fitness assessments? Why do you need to know if I'm flexible or not, and how much? Because you will have the baseline data, which means you know where I started from, and then you design something, and I want to go this way, and then as you see, there's a periodic reassessment, so you do that every 2-3 months, whatever you decide based on whatever I'm trying to improve, and then you see if whatever you prescribe for me actually works. And if it doesn't, you need to make adjustments, right? Okay, so you're cleared, your client is cleared, and you can do the fitness assessments based on which you can prescribe exercise. Which ones are you going to choose, and in which order? Basically, we use first the ones that won't affect the other ones. So if you take my heart rate, it won't really affect my muscular fitness. But if you take my muscular fitness first, then that will affect my heart rate, right? Do you have to do all of this? No. Which ones? I don't know. It depends. I would say all first three are just kind of important and basic, right? Then for 4, 5, 6, it really depends. If you want to do all of them, some of them based on my goals and whatever you think is important for me and whatever I'm telling you that I want to achieve. Okay? So we'll have resting heart rate, resting blood pressure, and then height and weight, BMI, we'll talk about BMI, waist to hip ratio, and of course, skin folds. Okay? Now, when we talk about cardiovascular assessment, we have plenty here. We're going to talk about most of them. Then muscular fitness, whether strength, or endurance, and then at the very end, flexibility. All right, heart rate. What is your heart rate? Is a number of times your heart contracts, which is the beats per minute. Okay, and we'll have hardening rest HR, we'll have exercise HR, if we can take it, like you have a polar right here, you can see it, or you can grab the treadmill you're using or the bike and you can see it. And then we'll have the recovery heart rate, which is the heart rate after whatever you were doing. If you have a low resting heart rate, that's a good thing. It shows that your fitness level is high. Good job. Also, if you recover fast, that's good. Again, because it is indicative of a higher cardiorespiratory fitness level. Okay? Men and women are different. Older people and younger people are different. But we're going to cover that as we go on. How are we going to do that? Manually? Okay? With an HR monitor or watch, as I just said, or with an ECG. We don't have ECG. We're not going to use ECG in our department. And it's not the easiest thing to do, also it's kind of expensive and it's more training. But doctors do it. Okay. We usually do manual because it's easy to learn and easy to do it. You can do it by yourself, and also through a monitor. Okay. Radial, brachial, and carotid. Which one do we use the most? B and C. This, not so much, because it creates a reflex. Okay, and our body thinks that blood pressure is dropping, so it may be kind of dangerous if you push too much. And in general, don't push too much. You use 2 fingers, you just touch, and then the second you detect the first one, then that's when you start counting. For how long? 1, 15 or 30. Okay, 30 of course is kind of more accurate, but then again, if it's a recovery heart rate, the more you wait, the more it's going to drop. So it really depends. In any case, it depends on the specifics. If you do 15, you have to do it times 4. Why? Because 15 times 4, it's 60 seconds, so you need your beats per minute. If it's 30, you do it times 2. Why? Again, 30 times 2 is 60 seconds, which is 1 minute, and that's what you're looking for. Okay? Again, which one you're going to use, it really depends. Blood pressure, measured in milliliters of mercury. And we have 2 pressures. Sorry. SBP, DBP. Both of them are going to be measured in the arteries. One of them, when the heart contracts and pushes the blood out. The other one, when the heart relaxes and blood is coming back in. Okay? If you have hypertension, it means higher blood pressure than normal. If you have hypotension, it's lower blood pressure than normal. And these are numbers you should remember. Below 120 and 80 is normal. 120 and 80 is not normal. Okay? It used to be. Now it is below. Make sure you understand that. Okay? So we have normal, pre-hypertension, and then 2 stages of hypertension, which is 140, 159, and 160. Sorry, 160 is stage 2 and above. 100. You definitely need to remember 120, 80, 140, 90. Okay? And that will help you figure out the rest. Blood pressure, it's really important. Of course, we're going to talk about hypertension later on. We need 2 resting blood pressures. You let them relax, for 5 minutes. They sit down. You take 2 recordings and 2 separate days and try to figure out if you see anything that is abnormal. It's really important the person to be seated and relaxed, and it's also important to use the correct blood pressure cuff. It happened to me in Plattsburgh last time I went for my physical. The BB cuff was smaller, so it showed that I had hypertension, and they changed it, and I was fine. Actually, I told the nurse to change it because we know guys. Sometimes we know more than them, okay? Okay, Korotkov sounds. So if you actually have a sphygmomanometer and you know put in your ears, you see the doctors hold it, you know, you have a sphygmomanometer and then you have a stethoscope you put in your ears, and then you're trying to figure out the blood pressure. You're trying to hear something with using the stethoscope, right? What are you trying to hear? These are the sounds you're looking for. You have the phase 1 through 5, and you're really interested in phases 1 and 5. Okay, when you start hearing that clear repetitive tapping, that's phase 1 of, and that's your systolic blood pressure. And the phase 5 is the one that we're actually using for diastolic blood pressure, although doctors write down phase 4 as well. Okay, it's a skill. If you want to do it manually like that and not use like a normal and electronic one, it takes time. You can learn it. It just takes time. It's a skill. All right. All right. We have a sphygmomanometer and a stethoscope. This is the sphygmomanometer here. The old one that had mercury. We don't use those so much anymore. We usually use those. How do you do it? You do it like this. You place it right here. You leave space for the stethoscope so you can hear. You don't put it underneath, because if you put underneath, it will rub against it and it's not helpful. It's not working like that. That's why you need to place it at the right point and use the right cuff size. Okay, this can just be attached here, or you can have to hold it. But whatever you're hearing, you have to relate it to this. So when you start hearing that clear tapping, right, you see the number, and then when it's gone, you see the number as well, and that's your SBP and DBP. Again, it's a skill. You just need to keep doing it. Practice, practice, practice. There's specific protocols. They're in the textbook. You can read how you inflate and so on and so forth. Body composition. One thing you need to understand right now is that we have a binary system. It's either fat or fat-free tissue. So it's either fat, or we take the rest all together. Okay, so muscle and bones and anything else, any kind of tissue, soft tissue, and so on and so forth. So having that in mind, you need to understand that by using that body composition, we can figure out who's obese, overweight, and the rest we'll see in a little bit. We can figure out the optimal weight, the desirable weight, the target weight, whatever. What you need to remember right now is that, why do we care about obesity so much? Well, we do care so much because it's there's a strong correlation, and a strong correlation means that if one goes up, the other one goes up as well, and they're really highly correlated, right? So more obesity, more chronic diseases. There's a direct and strong correlation between these two. That's why we care. Height and weight. You should be able to do it in centimeters and inches, kilograms, and pounds. I would love if you would sit down at home and figure out your BMI. When we do it in class, I'm asking everybody to do it, and I'm waiting until they do it. Please figure out your weight in kilograms, in kilos, and your height in meters. Square that. Divide this by this and figure out your BMI. It's not that difficult. Everything is in the textbook. You need to be able to do your own BMI before a client asks you to do theirs. Okay? Now, BMI is not perfect. Why do you think it's not perfect? Because you get a number, right? And based on that number, you're going to be classified into underweight, normal, overweight, and then obese. However, BMI does not take into consideration what kind of weight is this. So you can be 150 pounds with 25% of body fat, or 150 pounds with 5% of body fat. Is that the same? Heck no. So BMI is great, especially for, ordinary people, however you want to call them. But people who are exercising they have a lot of muscle. So BMI does not really care if your body weight is muscle or fat or whatever. It's just body weight. So that's a major problem with BMI. But we still use it in a lot of research, and it's very common. So it's not something that's going to go away soon or easily. Waist to hip ratio, another way to figure out, to get information, because now here we're talking about distribution. And that's important. Why? Because at some point, we were really interested in the absolute number of body weight. And then we're like, wait a minute. We started understanding that where that weight is equally, if not more important. So this is a very easy way. You have a tape and you figure out, measuring tape, and you figure out the waist to hip ratio. Waist, smallest circumference, typically 1 inch above navel, and hip, largest circumference around buttocks above gluteal fold. Okay? So you take those two measurements from the side of your client, right? And then you divide them. So you have that ratio, waist to hip ratio. And you need to remember those numbers. There's a risk for men if they're above 0.95, and for women if they're above 0.86. Now we can actually combine these two pieces of information. We can have this and we can have this. Boom, the more you know, the better. Because now we can combine the weight with where that weight is, the distribution of that weight. That is a really easy way. If you have access to that all the time, you can find the inches, you can find the weight in pounds, and then you can see where you are. Okay. Waist circumference alone, again, it's not going to be a waist to hip ratio, it's just going to be waist. High risk women above 35 and men above 40, very low, because very low is also concerning women less than 27.5 and men less than 31.5. Skinny folds, another way to figure out body distribution. So what are we doing here? We are measuring subcutaneous fat, which is the fat underneath the skin, and there is that assumption that if we measure that, that will, the hypothesis that represents fat overall. It's a pretty accurate way to do things. So the differences based on ethnicity, age, sex, as you can see. However, we use it a lot, and we have calibers in our lab in Plattsburgh. Unfortunately, now we can't use them, but we do have them. How do you do it? There's a specific protocol to do it, which is right here. Here you see 8 sites. 3 of those 8 sites, we're talking about diagonal folds. Okay, 1, 2, 3, that's important to remember. Also, I want you to remember that everything we measure is on the right side. And also an important thing is as you pinch, because you pinch the skin, right? So you can take it away from the muscle and then use the calipers, and the calipers just go over it, and then you have a kind of measurement that gives you a number. You hold the pinch. So you pinch with your left hand and use the calipers with your right hand. It looks like this. So it's always on the right side. You keep the pinch, and then you do this, and then you write down the measurement. You do everything twice, but you go in rotation. You don't pinch it like 5 times, because water is going to start going towards that area, and it's going to mess up with your readings. Okay, again, 3 are diagonal. Where are they? 1, 2, and 3. D, F, and H. Okay. How many sides are we using? It depends. It could be 3, it can be 7. It really depends. Here we have the example of the Jackson-Pollock nomogram. Okay, so 3, which 3 for men, chest, abdomen, and thigh. For women, triceps, thigh, and suprailium. So you put them all together, you get a number. let's say 90, and then the age is 35. So you start a line from here to 90, and if that was a man, that's this much, and if it was a woman, that was this much. I want you to see that if we keep it 90, like the number is still 90, but as you grow older, your fat is increasing. Why? Why do you think that happens? Because there's more fat located. It's not subcutaneous anymore. It's in between our organs. Okay, very dangerous kind of fat. But I wanted you to see that things change. Even if you keep the same body fat, as you grow older, the number you're going to get here, your percentage of body fat will go up. Biological independence, non-invasive, it's pretty easy. I'm sure you have gone to some gyms and you hold it, right? Or they have it on some other kind of device. The idea behind it is that water, it has to do with electric conductivity, and it's about water. Now, if we compare fat-free tissue with muscle tissue, where do you think we can find more water? In fat or in muscle? If you said muscle, that's the right answer, which means there's more water, which means the electrical signal will travel faster. So based on that, how fast that electrical signal will go from one side to the other, go through your body and then reaches the other side of whatever thing you're holding, then you get a reading about your body fat. Pretty easy to administer. Like there are a lot of advantages, but also a lot of disadvantages. You can overestimate, underestimate. You see there are a lot of conditions that have to happen before you actually do it. You see the error for skin fold is 3.5. For biological independence is higher. This is highly recommended compared to this in general. But of course, there are different tools in both cases. This I don't really care to cover because nobody really uses it anymore. But if you want me to, just let me know and I will. How to do with this and this slide. If you actually do this, check and make sure you understand there's a 15% use for a man when they're trying to find the ideal body weight. Anyway, all right, let's go to the assessments because we still have a lot to cover, right? And we are a 54-minute video, 55 almost. CRF, we're going to use the acronym. It means cardiorespiratory fitness. And what is it? The ability to perform large muscle dynamic, moderate to high intensity exercise for prolonged time. Okay, and it reflects functional capabilities of heart, as you understand, blood vessels, blood, lungs, and muscles. Now, why are we doing that? Again, we know the baseline. We can use it for exercise prescription, and then we can even use it to see if whatever we prescribe if it works. But also, as you can see, for predictions that have to do with medical conditions. Again, there are some considerations before you actually do it: alcohol, eating, so on and so forth. Nicotine, caffeine, all of these are affecting the result. Now, we can either have set distance, like you're gonna do this long of a walk or a run, and we're gonna figure out like your CRF based on the time of completion, or we can do the other way around. We can have a specific time and see how much distance you cover. That depends on the client and on many other factors, including what you have access to, pretty much. Now, VO2 max. VO2 max. What is VO2 max? VO2 max is a way to indirectly figure out, predict your cardiorespiratory fitness level. As you can see, it's milliliters per kilos per minute, okay, of oxygen. So the more oxygen you can use, the better, obviously. Now, you can do that with a 1.5 mile round test procedure or the Rockport 1 mile walk. Let's say you have somebody who is not conditioned, right? Which one would you use? The round test or the walk test? I hope you answered the walk test. So again, as I told you, you may be able to do both, but based on the condition of your client, you don't want to risk it. You go for the walk. I hope it makes sense. There are also step tests. Step tests are great. And here, what we're using is the recovery heart rate. There are specific height for the inch of the step. And as you can also see, when you're done with the test, it is gender specific or sex specific. So here, what you're going to do is you're going to use a different formula based on sex. And that's all I want you to remember from that. Now we have submaximal cycle ergometer test. So it's not possible every time to use a treadmill, right? And especially in Europe, cycle ergometers or bikes, right, are used more frequently than in the US. Now, it's definitely an alternative. It's not that it's better or worse. Sometimes if you're not used to cycling, you may have some local fatigue in your legs, of course. That will restrict you from reaching your VO2 max. Anyway, okay. So here we have a test that was developed by a couple from Sweden, Aston Rimi, and it's a 6-minute single stage test, and that's what I want you to remember. So the Aston Rimi test is only one stage. That's what I want you to remember. Then what you're doing is based on your sex and your condition, you pick the work, which is how much resistance on the bike. And then when you're done, you take your heart rate, and then based on if you are a man or a woman, and on the workload, you can figure out your VO2 max per liter, but then you need to adjust it based on age. So whatever you get here, you multiply it by the correction factor to get the actual VO2 max, right? That's another one. There are other tests that we're not going to talk about today, such as the YMCA. The only thing I want you to remember from the YMCA cycle test here is that it's not one stage, it's 4 stages, okay? That's it. There are definitely a lot of norms, which means we have tested a lot of people based on sex and age, and then we can compare your score to their score and be like, oh, you're excellent, or you're fair, or whatever you are. You can see all these tables in our textbook. Here, we're moving now to the muscle strength assessment. And we're gonna call that 1 RM, 1 repetition maximum, right? Which is pretty much how much weight can you move with 1 rep, okay? It's 1 rep, that's it. There are specific protocols, how to warm up, and how to go up slowly until you find your 1 RM. Every time you perform a test like this, make sure you follow the same protocol. Again, you compare your score to the norms that we have in the tables in our textbook. And again, based on that, you can put your client into a specific category. Endurance assessment, muscular endurance. Here we have the curl up test and the push up test. The curl up test is not going to be used anymore because we figured out that it doesn't really show us the endurance of the core muscles or the abdominal muscles. So this is something that we are abandoning, but the push-up test is one that we're still using. Again, there are norms. This is the push-up test for men, and this is for the ACSM for women. Don't get it all sexist with me. I'm not saying women are not strong enough or anything, but that is the way the test is designed, okay? So this is the pivot point for men, right? And this is a pivot point for women. As you notice, her feet are on the ground. They're not up here. This is not bending this way. The legs, the knees. Specifics right here, okay? And if you click on this, it will take you to the website. You can actually see a video of the test. And the flexibility test here, it's a measure, as you can see, not only of the lower back, but the hips and hamstrings. A lot of people have lower back problems nowadays, right? And sometimes associated with hamstring flexibility issues, because all these are connected, right? I'm sure you've heard of the term posterior chain. And in order to identify the flexibility for these muscles, a typical test is a sit-and-reach test. Again, you compare your score to the norms. I want you to remember that you're not wearing any shoes, you're crossing your arms like this, you don't do any jerky movements, you go all the way, you keep it for 2 seconds, and that's your measurement. Okay? Now, that's the thing that you have to submit that has to do with your LO. Of course, it can be used as motivation, right? Because you know where you are, and then you set a goal, and then you do some periodic assessments, and you see how you become better, and there's progress, and that's exciting and cool. But at the same time, frequency is an issue. Too frequent, not so motivational, especially if you're not supposed to see a lot of progress. Let's say you are testing your 1RM. How much do you think your 1RM in bench press will go up in a week? Not so much, right? So if I keep assessing your 1RM every week and you don't see progress, are you sure you can use those assessments as a motivational device? That's a question for you to answer in the LO that you have to submit for Sunday. Take home points, and we're done. We're just over 1 hour. The results of a health-related fitness assessment represent a potential time of change. Not all individuals are going to adapt to programming suggestions in the same way. Each round of health-related physical fitness assessments calls for a re-examination of the client's goals and objectives. Thanks, guys. Thank you for your patience. I'm wishing you an amazing week. Tomorrow we have office hours. So if you need anything, let me know. Log in between 8 and 12:30.